So one of education's biggest nightmares occurred quite 2 years ago when the COVID-19's very gruesome invasion felt quite in higher education in Africa, where education had to be paused for a while, revealing our unpreparedness to run full-time, robust digital learning was when we saw that we had quite some very porosity in our higher education and preparedness to run education on a full scale. Today, I'm here with one of the forefront people here at the Cape Coast Technical University who played a very key role in running the university's response towards the COVID-19 pandemic. And we'll be telling the story on how CCTU here in Ghana, central region, ran their way through from face-to-face to digital learning, their story, their response. Stay with us, we'll be right back. Welcome back on AAU Talks, and we're discussing CCTU's response to COVID-19. I'm Ajimola Chidaku, and today joining me is Dr. Kwabena Oteng Birimpong. He is the university medical doctor. Yes, he has CCTU. Doctor, welcome to AAU Talks.
Thank you very much.
Great. So the story has been told by some institutions how they did it, but I want to hear from you as a forward man at this institution leading the way. With your response to COVID-19, how did it all go? Take us.
Okay, so basically we woke up one morning and then we had somewhere far away, there was an outbreak of a viral infection. It was a bit murky, but eventually it was confirmed that there was an outbreak. We didn't really think that several thousands of miles away we're going to have to be dealing with those challenges. Mm-hmm. And unfortunately, as you are aware, most countries in Africa don't, or at that point, didn't have the capacity to deal with that level of like pandemics, infectious diseases. Unfortunately, the health system that we run here is just a reflection of what we have in Ghana and then in Africa at large. And so we had to quickly try and put things in place. It was extremely challenging because the school health system that we run here, even though it was along the same protective, preventive, and then promotive, it wasn't really to the point of dealing with such high-level infectious diseases. The good thing that, not the good thing, the chance that we had was that at a point at the beginning of the pandemic, the president announced that all academic institutions be shut down. Yeah. So that gave us time to try and do a lot of work. We put teams together. We looked at what the national policy was, what the Ghana Health Service policy was at the national level, at the regional level, at the district level. And then we also looked around to see what other institutions were thinking of doing, because we didn't want to reinvent the wheel. And then because we were in a system, we had to sort of relate to the system. And we're sort of like a small fish in a big ocean. Whatever we were going to do, we had to sort of relate. And then we also knew that there was going to be a point where we had to sort of fall to higher centers. So right from the beginning, we decided to align. When school went home, the main challenge we had to overcome was trying to get resources and disposables. If you, so let's say something that you'd have been paying, say, 20 cedis for, I'm talking about like medical supplies, we found out that we had to be paying 30, 40 times the price.
How did you
so
do
something like face masks. Ordinarily, we'll be using some of these masks for some of our procedures. But then the prices were jumping 30 times, 20 times, 40 times in certain situations. And that wasn't just it. Even being able to acquire them was a problem because they were not available. So the logistic challenge was the first thing we had to overcome. We had issues with hand sanitizers, to the point that we had to commission some local people to manufacture hand sanitizers for us. because they were basically not existent. So that was the first thing. We had to overcome the logistical challenge. Even sourcing funding to get some of the logistics, which were barely available, was even a challenge at the point. But the school came through for us. They supported immensely. Management made sure that once we could find somebody who could get them for us, they made all the finances available. Also, the government also came through. They supplied us. They helped immensely. They supplied us with some of the PPEs, the face masks, the sanitizers, and all that. So for that logistic front, the time that the school was on break, we had some time to try and organize some of the logistics. When the students were coming over, we had to also put in place measures to be able to sort of pick those who were going to be coming in, even those who had come into contact with people from home or even on their way to school. The school had a number of routes to enter the campus. We had to liaise with management and the security section to block off a lot of the smaller routes, so that we have let's say, I think at the point we had 2 main routes of entrance into the school, and at those entrances we had to be checking people's temperature, and then if somebody was sort of flanked, we had some checklists that we had to administer immediately, and then if we're suspicious, then we had to quickly refer them to the clinic, and the guidance of security will bring them to the clinic, and then we'll do further steps, further checks, and then if we thought that they were suspicious or they fell in within our checklist, and then we would sort of try and quarantine them. We'll ring the Ghana Health Service. They would come and do the test. In situations where somebody was positive, we would want to keep them somewhere, and then immediately we would have to start doing the contact tracing. So it was a lot of work, and unfortunately, we tried to do some of the things concurrently. Yeah. So as soon as the person comes in, that means that somebody else has to be thinking of doing a follow-up and doing contact tracing. At a point, we had to earmark a third of the university's residential accommodation for quarantine for students who had come into contact with people who had tested positive. So, and then also for people who had been symptomatic, we had to liaise with the Ghana Health Service to convey them to the designated quarantine centers so that they would be taken care of. And at a point, if you had decided you're going to quarantine somebody for a number of days, 7 days, 10 days, that means that you have to be taken care of, or you have to be thinking of how this person is going to feed, water, all that. So it was a lot of work to do, but I think what played to our advantage was the fact that we had some time when the school went on break. At the initial stage, we panicked, and most of the things we did were a bit reactive, but then leaning from what the Ghana Health Service, the Ministry of Health, the guidelines that they were trying to put forward, and even the WHO guidelines, we tried to do something that was very localized. Just to enumerate some of the other things that we did. On campus, we established a no mask, no entry policy. So right at the point of entrance, we check your temperature. We need to ensure that you are wearing your mask, and we needed to ensure that you are wearing your mask properly. Additionally, we dispatched hand washing basins with running water, soap, tissue, a good place, like a bin where you could dispose that off. And we had some of the stations had people like manning those places. So if you're going to class, if you're entering that academic block, if you're entering the administration, if you're entering the clinic block, you will be required to wash your hands. And we had diagrams which were depicting good hand washing. And there were times where if we had a number of people, we'd have like a nurse would come over, would do a demonstration of proper hand washing, just so that the people could learn how to do that. So we had that. In the classrooms, we had adequate spacing, so we did like a minimum of 1 meter spacing in the classrooms. Some classes had to be broken down because the class sizes were such that they would not permit us to have like the minimum of 1 meter spacing. So some of the classes had to be broken down. The school also decided to minimize personal, like in-person contact. So some of the classes were rolled on digitally so that let's say aside the practical classes which we couldn't have the entire span online. Let's say the demonstrations would be done digitally, and then the students will come in to do the in-person practice. But a lot of the lectures were rolled online. We had an online platform, and so that was done. We also embarked on an education drive, and with this education drive, it started from the health facility that we have here, where whenever people came in, we would educate them right from the point where they are doing the checklist, getting their temperatures checked. We will take advantage to educate them. I must say that one of the greatest challenges that we had with COVID-19 in Ghana and probably other parts of Africa was the myth about the origins. Some people, unfortunately, a very powerful religious sect was peddling some sort of falsehood about the origins of COVID-19. So that was a very big challenge because they had a significant following. And unfortunately, you had very, I'd say, prominent people also towing that line. So we had to embark on a very rigorous education drive to disabuse them and try and sort of drive home the actual origins that COVID-19 was a viral infection, and that it was airborne, person to person, all that. So we had to embark, and I must say that was, for me, I thought that was a make or break point, because if the person didn't understand the origins, then no matter whatever, if you ask them to wear their mask, they weren't going to, because in their minds it's 5G that is causing it. Yes, so they rather keep their phone away than wear a mask. So we rigorously tackled that, and then we did that with the academic body, the staff body, the student body. We tried to reach them online because as much as possible the school was trying to minimize in-person gatherings. And then we also formed teams to go around. So during classes, we would just interject for a few minutes and then sort of preach COVID-19, briefly talk about the origins, protection, prevention, and all that. So we tried to talk about all those things. And then during those visits, we would also ensure that people were wearing their masks, properly, and then also to ensure that they had their hand sanitizers, ensure that people were washing their hands as they were going to class. We ensure that the hand washing set had water there all the time. We had people on standby filling those water containers promptly, making sure that at every point in time there was soap, there was water, there was tissue to clean your hands when you're done. So we needed to ensure all those things were done. It was very tedious, but because we knew that it was going to have an overall impact on health, and then the academics in the school, we had to do all that. We also had a bit of challenge with the psychosocial aspect, where somebody had COVID, and then that meant that once people got to know, they would want to shy away from the person. So as much as possible, we try to isolate people without getting everybody else to know that, let's say, this person has had COVID, so that they are not shunned by their friends, the rest of the students. They'll go to class and nobody would want to sit near them. So whenever we picked up somebody who had COVID, as much as possible, we try to keep it under the wraps, so that they'll get the maximum care, and then they'll be able to reintegrate back into school. At a point, some people even had to take their exams in isolation because they couldn't come into the general public. And then there were instances where classes were in person, but because the people could not join class, we found a way of getting them to have snippets of the lectures. And then if there were quizzes and exams, they would not lose out.
Did you record a case?
Yes, so we had a number of cases. Yes, we had a number of cases. I also want to add that we had to implement some sort of system where people would call us and tell us if they had anybody who they suspected, because people were afraid. And once they were afraid, whenever they even suspected they had the COVID, they will not want to come out and even
The stigma
get
is
tested.
huge.
Yes.
I want to do that.
And even just knowing that they had COVID, people didn't want to go through that. So somebody will be sick, they'll be in their room. But we made it such that we could get information. And then once we got information, we acted on it. We would go fish them out. We would invite the Ghana Health Service. They would get the test done. If they were positive, we would deliver their drugs to their doorstep. And daily we would be checking on them via phone, sometimes physical, but at a distance to be sure that they were doing fine. And then if they were deteriorating, then we would make plans to transport them to the quarantine center and the treatment centers.
It's been a great ride through with Dr. Birimpong about how CCTU held down the COVID-19 and how they were able to administer all these directives and ensure that the campus stays strong and mighty. But we'll go for a break, we'll come back, and I'll let you know from his point of view, how were they able to reach out to the community, because they are the pride of Abra. So I would like to find out from them how they were able to touch the community as also a part of response to aiding them in community engagement. Stay with us, we'll be right back. Welcome back on AAU Talks, the voice of higher education in Africa, and we're discussing the Cape Coast Technical University's response to COVID-19. And I have with me Dr. Birimpong. Doc, the community is where you reside. You are right in the middle of Abra, so I think you are the pride of Abra. And the community, you mentioned that the myth, the perceptions, they were, the infodemics, they were just so serious. The critical factor, trying to bring out the resistance of the people, trying to follow the protocols and then the sanctions and all that. How did CCTU undertake? Was there any project to also try and then inform the community on how to understand this very deadly virus and how they could also preserve themselves from your point of view?
Okay, so the health facility we have here, it takes care of the surrounding communities. So it's not just for the university community. It takes care of the surrounding communities. And then we have a public health unit here. And basically what they do is a public health or community health unit. Basically what they do is they work in the communities. So for about 2 or 3 days in a week, they are in the communities. They visit people as a follow-up, people we had seen for, let's say, general ailments. They are in the community, so we took advantage of them. We deployed them into the community. We had community engagements in home as much as possible, even though while observing all the restrictions, to do some community engagements. And we liaised with some of the opinion leaders in the area. Where possible, we had some fora, and we have some community address systems in the area. So we really capitalized on that, where we had the opportunity to speak to the community using their public address systems. So those were the main things. And because we have people from the community visiting the facility, whenever they came in, we took advantage to have the talk. So let's say on a normal day when people came into the clinic, we take about 20 minutes or 15 minutes to have a public education on COVID-19. So we did some of these things, and I think that it helped disabuse people's minds, especially with the origins of the COVID-19 and what they could do in their own way to help prevent the spread of COVID-19.
One big perception, one big myth was that alcohol was one of the ways, drinking alcohol.
Yes.
Do you get these from the community?
Yes,
How did you handle that?
Yes. I think that because we have good relations with the communities, people would come to us with some of these questions, and then when our staff were in the communities, they'll get asked some of these questions. So it served as a very good opportunity for us to sort of cancel out some of these myths. There was a myth about alcohol, about some particular herbal medications, and then some people were saying that if they were on some chronic medication, let's say hypertension and diabetes and all that, it was time for them to stop taking those medications because they said it counted with the viruses. So we had to take advantage to sort of address all these challenges. and to let the people know that basically they had to be in optimum health. So if they were on any medication prior to the COVID-19, they had to continue taking those medications. And that was actually the time for them to make sure that their chronic ailments were under control, because all the statistics were pointing to the fact that people who had chronic ailments were doing worse or were worse off when they contracted the ailments. And I also want to say that when the vaccines became available, our facility was a focal point for vaccination. First, we had to vaccinate our staff when we were doing the health staff vaccination. And then also we organized the vaccination for the staff of the university, and then also was open to the general public. So whoever came in, and because of that, we also went into the community trying to get people to do the vaccination. So we organized some outreach programs to get people to take the vaccine and try and dissuade them from all the myth that was surrounding the vaccination. Yeah, so we did that too.
How convenient was that, trying to get them to buy the whole vaccine idea? Because it also came with different infodemics about the successes, the chip and all that.
Okay, so logistically we didn't have much of a problem because we already run a vaccination center here where we vaccinate children, we do the hepatitis B vaccination and all that. We do the yellow fever vaccine during the national project. I must say that the relation that we had with the community played a very good role, because people were already in the community. They go to the community very often. So having a familiar face to come and talk to you about something that you're not sure about was a bit easier. I think that it was easier for people to accept that because there were familiar faces. If you would go to the community today and say that, oh, I'm calling people, I'm come to talk to you about something, it will be easier for them even to grant you audience in the first instance. But if it's somebody you know who has been talking to you about your health all this while, in a way you trust that person to deliver a good health, let's say, health advice. So getting our staff in there to talk to them about this whole issue about 5G and the chip and all that, I think it was a bit easy. And so we had some resistance at some points, but I think that in the whole, because of the cordial relationship that we had established with the community, we were able to roll that out quite well.
Today, would you call that the storm is over with the whole response to COVID-19?
I would not say it's over. Maybe not as it was at the onset or somewhere midway. But I think that COVID-19 has brought up some benefits, in the sense that first, as a nation, we got to know how unprepared we were with our health setup. And then even as a university, we also got to be aware of how we're unprepared with our setup. And then riding on that, we've been able to put certain measures in place. Now, if something of that scale rises up, we have an idea how to tackle it right from the onset, because a lot of research has been done, a lot of publications, and we have a tried and tested approach. So that will be a good starting point. When the outbreak came up, we hadn't experienced anything like that in a century, so it was difficult. People were just throwing in things. At this point, let's try this. If it works, we continue. If it doesn't work, we throw in another thing. But now we have some tried and tested procedures. We know that prevention is very important. We know social distancing worked. We know that wearing a mask worked. We know that washing the hand worked. And the good thing about, or the good thing that the good things we can learn from it is that we have also realized that during the COVID outbreak, the occurrences of other respiratory infections went down. The occurrences of, let's say, an infectious disease like cholera went down. Gastrointestinal diseases went down. So we know that if we're to take our personal health very serious, we would not have to deal with a lot of the ailments that are burdening to our health system. Unfortunately, Ghana and in a lot of African countries, we have what we call the double burden of disease, where we are dealing with the infectious diseases and then the chronic ailments. that it's a burden on our system. But then we realized that the measures that we're trying to put in place for the COVID-19 helped with dealing with some of the infectious ailments that we have. So I think we've learned a lot. It is for us to try and learn from them, or put the things that we have learned into practice. And then with that, all the lives that have been lost to COVID-19 would not have been in vain. If we don't remain prepared perpetually, or if we are not on guard, we are going to wake up one morning and there's another pandemic and we would have to start from scratch. So yes, I think that there's a lot to learn from COVID-19.
I believe you may be aware of some mutations, variations of the virus, and we're hearing the monkeypox and the Marburg virus, Nipah virus. Lots of the names are just popping up. You express your preparedness right now. What message do you have for other health personnel who are across African higher education institutions all over the world, who also have a story to tell, like how you're telling, to be ready for these coming? What should they be doing now?
Yes, I think that from our personal experience, the first instance was the panic, because we didn't know where to start from, who to even talk to for very good, so I think that the first point is not to panic, but then to keep a baseline of preparedness. We shouldn't go to sleep, but have like a minimum baseline of preparedness, and then have sort of like a protocol. Because once we know that, okay, the next time we have to deal with something like this, we have to have A in place, then from there we'll escalate to B and C. Once they have those things in place, it makes it easier dealing with anything else, because tomorrow may not be COVID-19, but it's going to be another highly infectious virus. But once the baseline is there, and then we have the protocols with dealing with other infections in general, or very highly contagious infections, it's easier to adapt or adjust those protocols to the specifics. But if we are waiting for another COVID-19 to come, tomorrow it might not be COVID-19, it might be something else. Once we have the foundation very well laid out, and we have like a standard operation protocol, it's going to be easy meddling the storm in the future. Great.
So it's been a great time with Dr. Birimpong. He has told the story, the CCTU way on how they held coronavirus, COVID-19, also their responses, their strategies, and also their actions. And it's marvelous to appreciate how the institution held it all. Right at the beginning, we were all just struck by the whole virus, but later on, they were able to make good steps and then bring it to a point where they could control it. So this is where we wrap up on today's episode with CCTU's response to COVID-19. And I believe your institution also may have your story to tell. So we will come to you, you tell your story, and then we're able to tell the world how Africa held it together against this deadly virus, COVID-19. So we'll come your way next time. It's been AAU Talks, the voice of higher education in Africa. Be safe. Watch us next time. Have a nice day. Bye.